Greetings, everybody. Welcome to our Black DSPs Matter Part 2 webinar. We're just going to let participants come in and take a few awkward moments while people enter the Zoom room or the Zoom conference room or the whatever we call this virtual space of ours that we are all accustomed to at this point. So welcome. And we'll formally start in a few seconds. So until that time, just look at us, drink your water or coffee or lemonade or what have you. It is Friday, and we appreciate you all coming to this webinar on a Friday afternoon or Friday morning, depending where you're at. In summer, the first Friday of summer, so thank you for being here with us. We promise it's going to be worth your while. All right, we're going to just give about 10 more seconds and we'll begin. Okay, let's formally begin. Welcome. My name is John Raphael. I am the Director of Educational Services at the National Alliance for Direct Support Professionals. We're delighted that you have chosen to join us in we believe, a very important webinar, a very important topic. The National Alliance for Direct Support Professionals, our mission is to elevate the status and recognition and the development of direct support professionals. And direct support professionals, as we know, as you're going to hear, they are composed of primarily a minority, quote unquote, workforce. And that is a critical issue. Black women make up the primary and majority of direct support professionals, particularly working with people with intellectual and developmental disabilities in the United States. One thing that the National Alliance for Direct Support Professionals has done in the last 2 years, we have made some promises to direct support professionals and promises to our society in terms of what we need to do to raise the voices and the status and the recognition of direct support professionals. And two of those things, one is making sure that direct support professionals have valid information about their work and about their profession. We know that it's very hard for direct support professionals to obtain information about their work. And part of what we do at the National Alliance for Direct Support Professionals is offer an outlet for what we know is information that is valid and true, and as best as we can have it research-based. So the second thing that we have made a commitment to and a promise to for our workforce and for our society is we know that there are racial disparities that have been with us since the beginning of this country. And they obviously have blossomed in this last few years for whatever reasons. And that said, because the majority of our workforce is comprised by people of color and Black people, Black men and women, we needed to make sure that we as an organization were going to address what we believe and what you're going to see in this data that you're going to get today. We see that there needs to be some reconciliation when it comes to the racial disparities and the systemic institutional racism that exists. And we can say that it does exist. And what this webinar will be about is not how we're going to solve these things, but how we can take this data and what we know. These are the facts, and what do we do with it after? And that's for a follow-up webinar and follow-up work that we're going to be doing, obviously. So without further ado, I'm going to pass it over to my colleague and my friend, Nicole Dama, and she's going to introduce our esteemed panel. Nicole.
Thank you, John. I'm just going to pull up some words about our presenters today. But thank you, everybody, for joining us. And just a little bit of housekeeping. If you'd like to turn on subtitles, you can push the closed caption button at the bottom of your screen. And please note, we will share the recording of this webinar with all registrants, and you will also be getting a survey at the end of this webinar. And we will have a Q&A period at the end of this webinar, so if you save your questions until then, we'll have our presenters answer them. Thank you. So first today, we will hear from Robert Espinoza, who's the Vice President of Policy at PHI, where he oversees its national advocacy, research, and public education division on the direct care workforce. Next, we will hear from Andrea Price Carter, who is the Manager of Workforce and Technology Legislative Affairs at LeadingAge in Washington, D.C. Ms. Price Carter focuses on the critical issues impacting the National Association's mission-driven, aging-focused service provider members and 38 state partners. And lastly, today we'll hear from Dr. Amy Hewitt, the Director of University of Minnesota's Institute on Community Integration. And Amy conducts research on evaluation and demonstration projects about community services for children, youth, and adults with intellectual and developmental disabilities. I know we cannot hear you right now, but please give a round of applause for our amazing presenters today. Thank you so much for taking your time. And first, we're going to hear from Robert.
Thank you, Nicole, and thank you, John, as well. Thank you to the National Alliance of Direct Support Professionals for inviting me to speak in this important conversation. I also look forward to hearing from Andrea and from Amy and to your questions and engagement. I'm going to take one quick second to share my screen, and hopefully that will proceed without any technical issues. Can someone nod if they're seeing? You're seeing it. Okay, great. So as Nicole mentioned, my name is Robert Espinoza, and I'm the Vice President of Policy at PHI. We are a national research and consulting organization that's focused on strengthening the direct care workforce. And I just want to note one quick note on terminology. We focus on the direct care workforce, which includes direct support professionals, and it also includes other home care workers, as well as nursing assistants and direct care workers who work in a variety of residential care settings. So I'll be using the terms, interchangeably, although, I recognize that we are talking in many ways about different types of workers. That said, when we've looked at data on direct care workers and some of the data on direct support professionals, we have seen a lot of similarities. So we're going to, hopefully the findings and the ideas that I'll be sharing will still be relatable to all of you and to this conversation. Again, for those of you who don't know PHI, many people consider us the nation's leading expert on the broader direct care workforce, and I'll explain what I mean by that definition in a second. We do our work in a few areas. We do research, we do policy analysis to understand how government policies are shaping the jobs and lives of direct care workers. We engage in advocacy at the federal, state, and in some cases the local level. And we also design a range of workforce innovations related to training, advanced roles, recruitment and retention, and we educate the public on who are these workers, what are some of the key challenges they're facing. And we do this all in consultation with people working in government, with insurance companies and payers, with employers or providers, and with workers. We often say that we have a 360-degree perspective on this sector, and we've been around for almost 30 years. We are based in the Bronx, New York, though our work is national in many ways. By definition, the direct care workforce, we define them as workers who support older adults and people with disabilities in a variety of settings. They work in private homes, they work in nursing homes, and they work in kind of the vast array of residential care settings, like assisted living and other. Their titles do vary by occupation, they vary by state, and they vary by provider or employer. So at the occupation level, you might see categories like home health aides, direct support professional, certified nursing assistant, and so much more. And at the employer level, you might see different titles like care partner or care professional, or just the wide range of titles that an employer will often choose. And so, but in definition at its core, we're talking about people who are offering services and support to older adults and people with disabilities. Our research shows that Nationwide, there are about 4.6 million home care workers and nursing assistants throughout the country. A percentage of these workers are direct support professionals. We also know that because of growing demand, spurred by a variety of reasons, because we're seeing larger numbers of people turning 65, because disability rates are increasing, because people are living longer, and also because many direct care workers are leaving this sector, mostly to pursue better paying jobs in sectors like retail or fast food. The demand for these workers is astronomical. So we estimate that between 2018 and 2028, the long-term care sector will need to fill about 8.2 million job openings in direct care. And unless we improve the quality of these jobs, we probably will not meet this demand. We also probably need to imagine other ways of delivering services and support as well. We do know that by our data, the direct care workforce is now larger than any other single occupation in the US. So they are also critical to the economy, to the US labor force, and just to our way of living. And yet what we often find is that too often they are a critical, though an untapped part of what we might call the interdisciplinary care team or support team, this team of people that a lot of us rely on in our homes and in our communities, that often includes a wide range of people, from our friends and families to employers to physicians and nurses and social workers and others. Too often direct care workers, we find, are not properly optimized on that care team, which of course affects the delivery of care. It also can affect cost outcomes and a whole range of other benefits. By demographics, in terms of demographics, the vast majority of direct care workers are women, about 87%, 59% are people of color, and 27% are immigrants. And I am noting these in particular because this is a conversation on Black DSPs and about the issues of racial equity and racial injustice. And I think it's important just to start with just the diversity of this workforce, that we are talking about a largely female, mostly people of color, and increasingly immigrant workforce. Our data looks at workers specifically, through public data sets, so it doesn't really capture the gray market where consumers are often forced to hire home care workers kind of off their books and out of pocket, right? We can imagine that there is a high percentage of immigrants in that sector, but unfortunately we don't have much precise data on immigrants, especially undocumented immigrants in the gray market. And that's kind of a part of the sector that needs to be better understood and supported. The median age is 43, though our research does show that 1 in 4 direct care workers is aged 55 and older. So increasingly we're looking at a workforce that is older and in many cases supporting older adults and people with disabilities. As a conversation about racial equity and systemic racism in particular, we think it's important to really think about the history of this workforce. I often get the question of why is it that this workforce is so underpaid and undervalued? And one of the prime answers is that the primary demographic of these workers, or this workforce, which are people of color and especially women of color, have long been excluded and marginalized, not just in direct care, but in society at large. And one of the most profound ways that we've seen this was in the 1930s, when the New Deal was being discussed and debated in Congress. There were a number of members of Congress, senators largely from the southern states, that employed racist and sexist arguments to exclude home care workers from wage and overtime protections in the New Deal. From a gender perspective, they argued that women, they were innately able to deliver caregiving, and so thus it was women's work and it didn't deserve the same level of support, which we know is entirely incorrect and problematic. And many of these Southerners came from the South and states where they had benefited for years on slavery and Jim Crow laws, and they extended that devaluing of largely women of color into the way in which this workforce was adequately protected. Now, this exclusion was overturned in 2010 legally and then effectively in 2013. Yet what we still know is that across the country, home care workers only make on median about $12 an hour, and many lack full-time hours. About 45% live in or near poverty. So we continue to undercompensate and underrecognize this workforce. The median hourly wage for direct care workers is about $12.80. Many workers are relegated by their employer or by the economy into part-time work, which means that the median personal earnings is around $20,000 a year, and it pushes about 45% into or near poverty. Anyone who's ever done the math on how do you allocate $12 an hour across 30 to 40 hours a week will know that that quickly gets spent across the variety of expenses that we all have, right? So this is actually really pushing people into poverty, and it's affecting retirement savings in a sector that's largely interested in how to live and age properly. We've also looked at racial and gender disparities within the workforce, and I just want to highlight three specific ones, which is that in a workforce that is already marginalized, our data shows that women of color in particular fare worse than their colleagues. So the median hourly wage for home care workers who are women of color is about $11.13, but it's about $12.38 for white men. And that's problematic, right? I mean, it may seem like only a little more than $1, but that can be profound when you add that by the number of hours, number of weeks, months, and years, right? The percentage of women of color who are in home care living in or near poverty is at more than 53%, but it's only 38% in white men. Now, both of those are problematic, but it's especially problematic that women of color are more likely to be in poverty. Finally, the median family income for women of color is more than $37,000 less than the median family income for white men. And that's an important measure that looks at kind of the composite income within a family. And certainly when we think about the history of discrimination in education and employment, both based on race and gender, we see how that plays out in the median family income, specifically of women of color, into home care. So it might be that women of color are actually entering this sector, or now as a care partner in Stone Mountain, Georgia, and she says many CNAs simply do not get paid enough. You have a lot of responsibility taking care of members, and when you are not earning enough money to make ends meet, many people leave to find better care. And I think that's a really nice way to describe this horrible situation. Just really quickly, we also see that direct care workers often have limited training or advancement opportunities, which of course affects earnings. There are insufficient training standards at the legal level, especially for personal care aides and direct support professionals. There's a lack of specialty training on key topics like dementia care or LGBT competence as two examples. Too often training is didactic, and it isn't as experiential or as adult learner-centered as it should be. And there are few advanced roles where workers could really be better optimized, but they could also elevate their compensation and their titles to do better work in this. And of course, this is affecting the ways in which we are all able to recruit and retain workers. So two key stats, the turnover rate most recently among a certain percentage of home care workers was about 64%, and it's 99% among nursing home staff. This makes it increasingly more difficult to compete with companies in retail or in fast food. And many of us are talking about workforce shortages in many parts of the country. And the data we have on this workforce is also limited. We don't measure enough how many workers there are, turnover rates or vacancy rates, compensation. There is no federal standard occupational classification for direct support professionals, which limits our understanding of the level of support that people with intellectual and developmental disabilities need and have. And this gives us a little sense of where our workforce needs the greatest. I'm going to spend the last few minutes just talking broadly about solutions. Last fall, PHI released a new framework for what we consider to be the 5 pillars and the 29 elements of direct care job quality. We consider them to be quality training, fair compensation, quality supervision and support. How many of us have ever left a job specifically because of our supervisor, right? Respect and recognition, and real opportunity on the job. And within these pillars, there are a variety of elements. I'll only cover training for time purposes, but this is all available on our website. We argue that quality training should be accessible, affordable, and it should be relevant to the work we're doing. It should cover relational and technical skills associated with quality care. Communications and problem solving is absolutely a key part of succeeding in these roles. We argue for competency-based, adult learner-centered instruction. I know that and the National Alliance for Direct Support Professionals has its own competencies around direct support professionals, and we really argue for training that's based in competencies. It should account for cultural, linguistic, and learning differences, recognizing that we are different as people and we have different learning styles. And we should find ways to document and verify when we have been certified and when we've completed programs, so that as workers, workers are not, having to do the same training over and over, but also employers know that whether or not a worker has been properly trained. In January, PHI released kind of our signature report on the direct care workforce. We're calling it Caring for the Future, the Power and Potential of America's Direct Care Workforce, where we cover a range of areas. I would highly encourage people to access it on our website. But we arrive at 8 recommendations, and I'll close my presentation with just really briefly discussing these. One of them is really making sure that we reform and strengthen the financing system of long-term care. So often it's one of the primary reasons why employers and consumers aren't able to improve jobs for direct care workers. It's also one of the main reasons, services aren't properly funded for those of us who need it. But we really need to think about how do we strengthen Medicaid and Medicare where appropriate and other funding streams, and how do we reimagine entirely new financing systems. The second is, of course, increasing compensation, hourly wages, full-time hours, benefits like paid sick days, paid family and medical leave, childcare support, and other. How do we strengthen the training standards and the infrastructure of these programs so that everyone is equipped? Sometimes training is in person, but a lot of cases now we're seeing virtual or hybrid approaches. And how do we make sure that those are effective and well evaluated and funded? How do we fund workforce interventions like advanced roles or recruitment and retention supports? How do we improve data collection? I mentioned the need for a new occupational code on direct support professionals, but certainly states also need better systems. And Amy, as a researcher, I'm sure can speak in depth about some of these challenges and where we've improved. We need to center more workers in policy and practice, and we need to rectify structural gender and racial inequities. Finally, we need to shift the public narrative so that we're understanding the public and people in government in particular are understanding these issues. Under systemic gender and racial inequities, we argue for strategies that are addressing those barriers and that are addressing diversity, equity, and inclusion. We need more workforce interventions that are equity focused and really looking at disparities across race and gender and sexual orientation, just to name a few. And more supports for immigrant workers, because they are becoming kind of a bigger part of not just the US labor force, but of this workforce. The final quote I'll share is from a care coordinator in Bronx, New York. She said, "I think the role of the home health aide should be considered just as important as any other healthcare role." And that's what we argue very much so, is that we really need to think about direct care workers and direct support professionals as a critical part of the fabric of healthcare, of long-term care, and of services and supports throughout the country. Thank you so much for listening to me. I'm going to stop my sharing, and then I'm going to hand it over to my friend and colleague in the field, Andrea.
So good afternoon. I'm also going to share my screen, pull up my slides. Okay. And can you all acknowledge that you see my screen and slides? Yes, okay. So again, I'm Andrea Price Carter with LeadingAge. And just one moment. Okay. If you're not familiar with LeadingAge, we are a nonprofit aging services organization. And so our members they run the full gamut of aging. And so we offer anything from low-income senior housing, assisted living. We have skilled nursing facilities. We have members that also provide home and community-based services. And so it's the full spectrum of aging. And so our members primarily would as well hire the direct care workers. And so the term that I use most frequently is direct care. And so as Robert has shared, it is certainly one that just, it's broad, but certainly encompasses all who are in the sector. So I want to just point out some of the demographics that Robert has highlighted, and so I'll just move very quickly through them. We've really been concerned with the fact that we're having the older population double. We are certainly in a position where, as Robert has mentioned, there's a demand for direct care workers, which is outpacing society, particularly when you look at what's happening with the older population. And then certainly with the COVID-19 pandemic, it really exacerbated the workforce challenges that a number of our members, as well as families and caregivers, experienced. And so what we certainly realize is that it shined a spotlight on a number of the issues that direct care workers are experiencing as it relates to the healthcare system. Fundamental to a lot of the problems have been highlighted. There's issues around training, recruitment and retention, certainly advancement opportunities that have been elevated already. And then with a result of all of what has been occurring, the turnover rates, and I would say the low pay has led to a number of staffing shortages. LeadingAge, I just want to just point out that part of the solution we felt is that we really needed to elevate the concerns that we were having as an organization. Part of that solution was to issue a report that's referred to as Making Care Work Pay. And the report was one that really spoke to the importance of a livable wage for all direct care workers. So that had been fundamental in the work that we were doing from an advocacy and policy perspective. What I wanted to do today was just highlight some of the federal policy proposals that have been introduced. Certainly Congress has taken a number of efforts to try to alleviate a number of these issues that we've laid out. Just starting more recently, we've had a number of COVID funding packages, and the most recent one that was enacted in March, I just wanted to share, did have some significant funding, particularly that went to state and local governments. One of the options that they would be able to use the funds for, and that was through the American Rescue Plan, was to be able to increase the pay for all essential workers. So direct care workers would certainly be a part of that. So they would be able to provide an additional $13 per hour with those funds. It is a state option, and so that is something that we would like to see being mandated, but we certainly saw that as one step in the direction of providing additional support when needed. There were a few other provisions in the American Rescue Plan, particularly that relate to the federal FMAP match. And so there's an opportunity for 1 year to have a higher rate of reimbursement that comes through the federal government. And as a result, that puts states in a position where they would be able to use those funds to do the kinds of things such as recruiting new workers, particularly being able to address hazard pay if they chose, or maybe even providing overtime or paid sick leave or additional increases that would help support direct care workers. And so I'll just bring you more current. I think that you've heard a great deal about the infrastructure plans that are currently taking, I would say, effect or have been brought into light. We really were in a good position to elevate the importance of direct care workers and essential home care workers, particularly with the Biden administration. So part of their efforts along with the COVID relief, excuse me, was also to have an infrastructure plan, excuse me. And so with that, the first one that was released was the American Jobs Plan. So this was a two-part effort. And the first, I would say, most significant part of the plan was that it did allow for increased funding for HCBS related care infrastructure services. Quite significant that it was $400 billion that have been allocated. And essentially just telling Congress that this is where he would like to see additional efforts made, particularly to hire more caregivers, to give opportunities where their pay could be increased. There could be efforts certainly that would allow for stronger benefits, and just generally increasing the entire infrastructure, particularly at the state level, that would be able to support these workers. The American Jobs Plan also included an investment around workforce development and worker protection. Part of that would certainly be opportunities where increased apprenticeships and other job-related development initiatives could be funded. So with that investment of $48 billion, it's estimated that you could see as many as $1 to $2 million, particularly as relates to apprenticeship opportunities. So the second part of the infrastructure plan that came through the Biden administration is the Americans Families Plan. And so this is to go, I would say, side by side in helping to not just look at how can we improve the care infrastructure, but also what particular supports could be helpful to to families, and just to middle Americans. And so what they have done is to put forward a comprehensive paid family and medical leave plan. There are opportunities where there could be additional child care and family tax credits, as well as areas that look at just the child care system supports, as well as higher education. So they would go, I would say, together to create what we broadly speak to as the care infrastructure plan. So what we have witnessed, just as a matter of fact, yesterday, you probably heard in the news, and we have tracked very closely, how would we take those care infrastructure proposals and move them forward into a legislative vehicle? So probably on a dual track, there has been some discussion about the broader infrastructure framework, but equally important, again, is the whole care infrastructure proposal that has the direct impact on the direct care workforce. So we have been able to witness just yesterday, as I've shared, the introduction of a comprehensive bill, the Better Care, Better Jobs Act, that would essentially take that model provisions from President Biden's plan and put that into legislation. And so what we are able to do now is see that a lot of those provisions, such as being able to increase FMAP, that's been included. Opportunities where states, in order to get these additional funds, would essentially have to promote recruitment. They have to prioritize wage and benefits that would be directed to direct care workers. They have to regularly update or have plans that they would submit that would address how would they be updating the workers' pay. So there's also programs that would allow for additional access to home and community-based services, and highlighting where and how people with disabilities would be accessing these services. So there are a few other proposals that I just wanted to mention. Most of them relate to training and workforce initiatives that particularly direct care workers would benefit from. And the first is the Direct Support Worker Training Reimbursement Act. And this is a proposal that was introduced during the last session of Congress that would essentially look at, again, increasing the federal match for training, particularly for home and community-based care workers, and giving them a higher FMAP that comes through the Medicaid program. The second proposal is the Molly Baldwin Upskilling of Personal and Home Care Aides Act. And again, it was introduced during the last session, so we're pleased to see that it was once again reintroduced. And so this legislation would be one that would look at, well, how can we look at some of the existing training models that could bring new workers into the system, particularly looking at home and community-based care. Once again, we're able to see the reintroduction of the Direct Care Opportunities Act. And so this is a proposal that will go to a number of entities where they could actually look at improvements around recruitment, training, and I would say delivering plans that would be comprehensive in nature and how they could actually fund and increase the number of direct care workers across the country. It's very significant that the funding is allocated to be about $1 billion. So I think that that is a big step in how we could really essentially finance programs. And that's largely been one of the areas of concern. We have ideas, but we don't have the financing behind it. And then the last one that I will highlight is the Home and Community-Based Services Access Act. While this has been a draft bill that's been circulated, we're expecting it to be introduced. However, it is one that looks at more comprehensively, how can the federal government actually raise the level of FMAP increases and just ensure that there's a greater level of opportunities for ACVS services to be received across the country, and for those who are in need of these actual care and the services. So just two others that I will highlight relate to the data collection and equity. Particularly, there is the recognition that direct support professionals do need to have standard occupational classifications, as Robert has mentioned. And so there's actual legislation that has been introduced that would essentially cover that particular area. And then there was, I would say, a very symbolic bill that was introduced that is broadly referred to as the Domestic Workers' Bill of Rights. And so there's the recognition that there are opportunities that we could certainly improve and strengthen what is often viewed as discriminatory practices and the lack of benefits and health necessities that domestic workers endure. And so this particular proposal would address that. So in conclusion, I just want to highlight that we're at what is a fundamental opportunity to make some significant changes with the financing, the training, the entire focus in which direct care workers are operating. And so largely because we have the commitment from President Biden through his infrastructure proposal. We have several bills that have been introduced in Congress. And so this gives us an opportunity to move forward with being able to really make some significant efforts in how we as a country can look at being in a much better place as far as the financing of proposals that would address these areas. So with that, I will close and thank you and be available for questions later. And I'll turn it over to Amy. Let me stop sharing.
Thanks so much, Andrea and Robert. Robert, for giving us the history and then also for just giving us the hope. The Biden administration gives me great hope around workforce issues. More, I think, has come out in terms of legislative proposals in the last year than I've seen in most of my career. So thanks, NADSP, for inviting me. My hope is that our work as a researcher gives Andrea and Robert and the advocacy wings that they work in, as well as NADSP data and ammunition for your advocacy. And so I was asked to just share briefly, I'm going to go through this very rapidly because I only have 15 minutes, some really critical data that we just are releasing. I mean, this is sort of coming out fast and getting released very fast, related to DSP experiences during COVID-19. And as a part of that, uncovering data that speaks to low wages and some racial disparities. So I'm going to share the data, and then I look forward to us being able to have a conversation about it. As a quick reminder, the Institute on Community Integration, where I work, and NADSP, beginning in April of 2020, at the beginning of COVID, have been doing a series of surveys to try to understand from the perspective of the workers, not their employers, the perspective of the workers, what their experiences have been themselves going through COVID-19, global pandemic, and then their observations of people that they provide support to. I'll only be sharing a tiny little bit of the data about the workers today with you, but leave you with links related to the rest. So we launched a survey in April of 2020 and then did a 6-month follow-up in January, November to January. The survey was in the field in 2020, 2021, and that's what I'm going to be sharing with you. We have a third survey, a 12-month follow-up survey in the field right now. So thank you to anybody who's on this webinar that completed either of the prior surveys, and I'll put a link to the 12-month survey in the chat as well. But these surveys reached just under 9,000 DSPs. Each one that we fielded came in just right under 9,000 completed surveys. So it's a pretty large sample of direct support professionals across the country. In the second survey, we decided to ask questions about demographics. The first survey we didn't. Very short and easy to get a large response rate. And once we got that, and then as COVID was unfolding and there were so many things related to disparities in working, in the actual disease itself, that we decided to add the demographic module to the second survey, and it's in the third survey. So this data comes out a bit different than the data, the Bureau of Labor Statistics data that Robert talked about, with the workforce being a little bit less diverse than the BLS data shows, but still not completely radically different in the sense that it is still, our data shows that it's still a very large portion of the workforce are from diverse racial, ethnic, and linguistic backgrounds, and consistently shows it's predominantly a female dominated workforce. And just intuitively, when you think about the demographics of the workforce and you think about inequities and injustices in the United States, it shouldn't be surprising to any of us that the wage inequities, wage disparities, perpetually low wage, lack of affordable benefits, all these things that have plagued this workforce for 30 years have plagued other professions that have been predominantly female dominated and low wage. So this data just supports the argument kind of in contemporary ways. To give you a sense of where people who filled out this survey worked, over half of them worked in an agency or facility site. About 31% worked in individual family homes, an in-home kind of working situation, and 8% worked in employment. One of the things we don't talk enough about in this field is that we talk about low wage entry level positions, and yet a very large portion of direct support professionals have had formal education beyond high school. This particular sample, 73% had education beyond high school. And of the nearly 9,000 DSPs that we surveyed, almost all of them said, yep, we're essential workers. At the same time, we looked at the state's plans around COVID-19 for home and community-based services, and to find out how many states identified DSPs specifically or home and community-based services at the beginning of COVID. And only about 17 states even came close to really identifying officially this workforce as essential workers. So when we looked at data around wages, the mean wage for DSPs completing the 6-month follow-up survey was just under $14 an hour, and only 30% across groups identified that they got some kind of extra pay, whether that was some sort of salary augmentation of $1, $2 an hour more, or some kind of a bonus that was in recognition of them working during COVID-19. So only just under a third got that. Of those that did get extra pay, 48%, so just about half, got $1 to $2 an hour additional. I don't know about your states. In the state of Minnesota, kind of the typical salary augmentation most essential workers received if they were in hospitals or working for the Target or wherever was $3 an hour. So even those that got some extra pay in this field got less than the typical person working as an essential worker. The other piece is that 21% got a lump sum bonus, which is, okay, that's great, but it's nothing permanent. It's a short-term kind of augmentation. When we looked at wages by race group, you can see that Black, African American disabilities made less money. And when we ran statistical significance analysis, they receive a disproportionate lower wage. It's statistically significant than white DSPs and other groups of DSPs. So that's problematic. And again, it shouldn't surprise us, because if you look at any occupation in the United States, Black and African American workers tend to make less money. We also asked about household income, and not surprisingly, about 70% of DSPs are the primary wage earner in their home. So if you go back to what that average wage was, which is just under $14 an hour, and you're the primary wage earner in your home, it's very difficult to raise a family on that wage, which Robert's data spoke to that. When we looked at household income by race, households with under $40,000 household income, Black and African American DSPs were much more likely to have household incomes under $40,000 a year. And just as a point of comparison, the federal poverty level for a family of 3 is just around $22,000. And if most benefits in this country, Robert talked about, well over half of direct care workers receive some sort of government assistance. And if you take that and look at 125 to 150% poverty level, which makes you eligible for most, you begin to see how DSPs rely pretty significantly on other government benefits. We asked questions around how their work life had changed, so particularly around staffing and scheduling. Those of you who work directly with direct care workers or are a direct support professional, you know that your work life changed pretty dramatically during COVID-19, with people working more hours than they're typically scheduled to work, from working a lot more hours to being furloughed. I mean, that's how radically people's work lives changed. Many had to work, about a third began working in different settings. So they didn't show up to work at the same place. They had to go work with different people. And nearly everybody took on some different roles. When you begin to look at the working extra hours and work-life balance by race, there were some statistically different findings where participants had a significantly higher percentage of not working more hours. White DSPs were much less likely to be working a lot more hours, and Black and African American workers were much more likely to sit in significantly higher number of hours per week. That then we began to look at a few factors. We asked a question around work-life status. So 6 months into COVID-19, 40% of the people who completed our survey said that their work life was worse. And 14% said it was much worse. And then about 38% said, oh, it's about the same. When we looked at that work-life status by race, there were significant differences with Black and African American workers being more likely to say that their work life was better, their work-life status was better. And you could hypothesize why. There's a lot of potential reasons to explain that, but one is they were able to work more hours and have more income as a result coming into their households. Another analysis that we did was to look at whether people who received wage augmentation reported that their work life was better. And you can see on this slide, the blue is they received an augmentation, the red is no augmentation. And people who received augmentations reported that they were much more likely to report there was some improvement in their work-life status. It was as good as it had been. We also looked at whether or not a person's work-life status was influenced by their hourly wage, and the only statistically significant finding was that participants that felt their quality of their work life was about the same at the beginning as it was at the beginning of the pandemic were much more likely to be the lower wage earners. So, I mean, the story here is wage matters. And people have a better quality of work life when they're making enough money to live on. So what's this all mean? It means call to action. It means that DSPs really need to get to know their elected officials. It's very easy to do. You can, there's a link in this slide that will go into the chat. You can enter your zip code and have the addresses, phone numbers, and how to reach all of your elected officials at your fingertips. And we have to demand change. We have to ask for change. All of the policy proposals that Andrea shared with you, you all need to be calling and saying to your elected officials, make this happen. And and share the need to do that with every other DSP, all of your family members, your neighbors. We have to, until they start hearing from the workers themselves about the critical importance of this, these policy changes, I don't see things changing too much. One of the things that we're doing is trying to push out a series of policy research briefs around the data that we're gathering and analyzing. We'll do a whole series from this COVID-19 series of studies. And again, the unique thing about this research is it's from the mouths of direct support professionals. These are simple 2-pagers that you should be sending to every one of your elected officials. And then the call to action really are those proposals that Andrea spoke of. So that is the data that I was asked to share. And I think it poses a lot of questions. So that's the good thing about research, is that good research captures and results in more questions than it does answers. I think my takeaway is there's absolutely no reason to think that in this field, the challenges that we see across our country related to wage gaps for women, for people of color, exist in our industry too, and are disproportionate. And we need to take action to make that be addressed in a very clear and concrete way. And we need to understand why they exist specifically in our industry. So thanks, and I'll stop there and turn it back to John.
Thank you, Amy, Robert, and Andrea. Well, you've met our objectives of giving us data, and of course, data doesn't necessarily lie. But what we'd like to do right now is just have basically a casual conversation, obviously between all of you. And right now, I'd like to invite anybody that has any questions or any comments to put that in the Q&A, and we'll get to those. But I already have a whole list of just queries. And first and foremost, I think, what do you think are the similar themes between each set of data and information that you have all shared? What is there a common denominator? And as obviously this is a webinar on Black DSPs Matter, are there things that are necessarily common denominators as it comes to race or racial disparities? So I'll just, and again, just be, we know, just talk.
I mean, I think certainly Amy covered some of these points. I mean, I think that you'll see similarities in terms of low wages, kind of accessing public benefits because of course of low wages, and just demographics, right? I mean, we're talking about a workforce that is comprised in many ways of people of color, of women, and of immigrants. I think probably Amy's research goes more deeply into the experiences and the ideas of workers, whereas ours tends to be more relying on public data sets that's describing their job characteristics and their demographics. But I think the overarching theme is reaffirmed, which is that this is a diverse workforce, but it's an undervalued workforce. And it's in many ways women and people of color who are bearing the brunt of this lack of support.
Thank you.
And certainly I was addressing from the policy perspective, but the proposals that are currently pending, as well as the infrastructure plan, address all of these areas that have been highlighted in terms of, what is the detriment to being able to carry out these jobs. So I think that message has been heard, and it's a very positive step in place that we're in, that we have an opportunity to turn that around from a legislative angle.
Mm-hmm. Mm-hmm. Yeah. Amy, have you any common denominators given Robert and Andrea's information as related to the COVID results?
Yeah, I mean, I think the biggest common denominator that I heard is no matter the angle you're looking at these issues, whether that's from a policy perspective or a practice perspective or a human life perspective, the issues are very systemic, and they're about things that are much bigger than any given employer and any given sector. It's across our sectors of aging, physical disability, brain injury, developmental disability. It's across all those sectors. And it really goes deep. It's deeply entrenched in societal perceptions of care, of who caregivers are, of their worth. I know I very intentionally try to talk people out of using the word care and caregiving, because I think it connotates to elected officials things that are free. And we do caregiving for our family members and our loved ones, and we don't pay for it. And it shouldn't be that way, but it is that way. And so thinking about these professions as really necessary, valued, worthy, essential, we must have them, I think is just so critical. So those are some things that I heard.
Yeah, absolutely. One thing, I mean, I think the most hopeful that I've been has been this last couple months, given what we have seen come out. And this is where, Andrea, thank you so much for telling us about these initiatives that I bet most of us don't know. These things are either on the table or being pushed to not only improve things, but to I think turn a different direction. And I guess my question is that, and it's hard not to exclude politics, right? It's almost impossible not to exclude politics and politicians. And I don't really want to talk about them right now, but unfortunately, so Joe Biden, what, 3.5 more years. So when he is out, right, and his administration is out, I guess the question is, are we absolutely at the mercy of an executive administration to help change this trajectory and get direct support workers better recognized, better paid, better valued? Are we dependent on that? And if we are, what do we do?
I think you're absolutely right, and we are dependent. And I think that Amy expressed very well that you need to be in touch with your legislator, your member of Congress, your senator, to speak to the importance of, and I'll just use a term that's just commonly referenced, the care infrastructure that is upon us. It was hopeful, or I should say it was positive, that President Biden has also stated, along with the negotiations around the bipartisan infrastructure, that he would not be supporting that unless he also gets the care infrastructure, where it includes the broader, the families, the higher pay for direct care workers. All of that needs to come at the same time. It may be on two different tracks, but without one, there is no other.
Yeah.
And so that is where I think that we're in a very good position, but there needs to be that push. There needs to be that support. There needs to be that voice from the public, so that, your policymakers are aware of the importance and the opportunity.
Mm-hmm. Mm-hmm. And just diving into some of the information you shared, Andrea, could you explain FMAP to direct support professionals? So that's a very complicated thing. I can't get my head around it.
And I have to apologize too, that it's the reimbursement, and perhaps even Robert could do even a more comprehensive job. It's the reimbursement that the federal government sends to states for the Medicaid program. So it's a dually funded program. And so there's a ratio that the state provides, there's a ratio that the federal government provides. The higher the ratio that the federal government provides to the states, then is in turn passed on to the Medicaid providers. So many of the services or the home and community-based services are funded through the Medicaid program. So if states have less money coming from their state revenue or their budgets and more from the federal government, it frees up and allows them, when it's especially explicitly stated the funds must be used in this way, then, and it is a percentage, then they have to use it and they have to apply it. And so, and the issue is, and part of the challenge is that HCBS services are not mandatory. So every state, it could vary in terms of what they may provide. So the whole problem is really a financing issue. And that's where there needs to be the discussion about the higher FMAP reimbursement, along with, you know, what can states do to make this these services more available.
Mm-hmm. That was fantastic. And the only item I would add is that, you know, it's important to note that Medicaid, you know, in this system, you know, funds both the services and supports that individuals receive, but it also is the primary payer and kind of funder of direct care job and job quality, right? So in many ways, it's also funding the wages and the training improvements, et cetera. And oftentimes we'll hear in states that employers will say, you know, we don't have, you know, enough Medicaid funding or higher enough reimbursement rates under the state to even deliver services, much less to improve jobs for workers. And so it's the systemic ways in which both services and jobs are kept substandard.
And there's another, something that jumped out at me in all of this. This comes from your information that you shared, Robert. And this scares the daylights out of me, man. 8.2 million job openings needed by 2028, right? So again, going back to why we're doing this webinar, as we look at the demographics of who will be doing these jobs, how do you believe that, I think, the institutional systemic racism that, you know, we talked about that in our first webinar, kind of what that is and how that's defined and what the elements of that are. How will that affect getting 8.2 million people? Will that be do you believe that will be a barrier? You know, the things that unfortunately are the institutional racist things, to get I don't know where these people are going to come from. And if you're saying an immigrant workforce is increasing, how's that going to play out when there is such unfortunate racism in our system and in our society?
Yeah, it's a scary figure. I'll share a few thoughts, though. I'm curious what Andrea and Amy think as well. The few points I would make there is that I think, you know, when you look at that 8.2 million figure, it includes, you know, a million or so jobs, new jobs that are being created because of growing demand. And it includes a certain percentage of people who are simply exiting the labor force, mostly to retire, right? But a large percentage is people who leave direct care for other sectors like retail or fast food. And any of us who have ever seen in states, you know, job applications for home care workers versus job applications for Macy's or McDonald's, et cetera, you're surprised. I'm always surprised and somewhat horrified at how better the jobs seem in fast food and retail. I mean, signing bonuses and workable schedules and all of that, right? So it is a real scary situation here. In terms of systemic racism in particular, the 2 points I'll know is that, you know, part of it filling that demand will be about looking at both what is the demographic of workers that are most best positioned to fill those jobs, and how do we recruit more workers into that pipeline? And one of the answers is immigrants. And we know that currently about 1 in 4 direct care workers is an immigrant, but there is an untapped potentially of undocumented immigrants who are already in the country. Or LeadingAge has put forward some really phenomenal ideas around building a pipeline from abroad to create kind of more caregiver jobs for home care workers, more direct care worker jobs. So, and yet the racism, the hysteria around immigration is rooted in racism, right? And so we're gonna have to sort through that as a country. The second is that the political debate on Medicaid as a program, which is the primary payer for long-term services and supports, has always been fed and informed by racist ideas, right? There is a think tank world on the conservative side that is trying to ultimately get rid of Medicaid because they believe, and this is the racist argument, that it's being kind of exploited by, largely people of color who, don't need these jobs, don't need the, don't want to work and are kind of exploiting the Medicaid system. And there are supposedly, a lot of fraud from immigrants, et cetera, right? And that's racism, right? And the idea is it feeds on this long held trope that people of color are exploitive, they're sneaky, they're doing all this stuff, right? But the impact is that when, states, and we've seen this, defund Medicaid, who suffers? It's low-income people with disabilities and low-wage workers who rely on Medicaid for both health insurance and long-term care, right? So I do think racism has a big impact on this workforce. Yeah.
And I just have to thank Robert for elevating the LeadingAge, what is referred to as the Imagine initiative. And so it's a broad set of recommendations that we look at really amending some of the visa categories to allow more workers to be available to aging services providers. Mm-hmm. And it's not certainly to displace the US workers. In order to qualify, there needs to be a scenario where an employer would have to show that no one was able to actually, or they were not able to fill the jobs for a certain period of time. And so in terms of the exploitation, there's also, I would say, provisions that we would say the person would become a citizen, they would be able to bring their family, and then we would provide them with the supports. So such as if they needed help with housing or transportation. So it's a comprehensive proposal in that you're not just trying to get people to work in a setting that may be perhaps not beneficial or viewed as unfair. So I think that it's gotten more attention. Certainly there's a number of hurdles, and especially looking at, while the Biden administration is looking more broadly or supportive of immigration policy, a lot of their proposals, or the proposals currently that have been put forward, don't look at bringing additional people in. And so that's the difference in what we're also saying a part of that discussion should or could be to look at some solutions. So not just solely domestic based, but as well as the immigration related initiatives.
Mm-hmm. Mm-hmm. John, this is Amy, and I'm going to answer your question kind of from a different lens a little bit. And I think a lot about what do we know about who uses these services that we're talking about, whether it's nursing home, intermediate care facility, home and community-based services, in-home state plan PCA, home health aid kinds of services. And when, particularly in services and supports for people with intellectual and developmental disabilities, but across others too, there are certain service models that some people don't use. A good example, a study just came out of Minnesota. We did not do the research, looking at utilization of home and community-based services. And in Minnesota, Black, African American, and other diverse racial, ethnic, and linguistic populations are much less likely to use home and community-based services or ICF services. they're much more likely to use in-home PCA services, different systems, different funding. And when I think about how the systems were created and for whom they were created by and for white middle class and upper class families. And I think part of the systemic racist issues that we're dealing with in the field, we have to really look at that. And are we delivering the kind of service and support that people want and would find useful? And in many communities, the whole concept of people with disabilities living independently on their own, it's not how they think of family and multi-generational ways in which you support one another. And so I think you have to look at it both from the workforce side and who you're recruiting in, but you have to look at it from the service side too. And if a service is not liked and beloved by a certain group of people, it's probably not likely that workers from those communities are going to necessarily gravitate to the work either. And so I think we have to look at it from both angles.
That's great. Yeah, no, that's great feedback for that question, because that question, it's going to just continue to fester. I mean, we hear it every day: the workforce crisis, the workforce crisis, the workforce crisis. And Amy, you've so eloquently said this is not a crisis. A crisis does not last 35, 40 years. This is a systemic failure. And it's like an onion, right? I mean, when you start to peel the onion away, all the different layers, and yes, so the racism piece is there too, but the gender inequities, just the notion of people with disabilities or older people in our society being devalued, all of this, I guess, comes into this big old stew that we're in the middle of. And I think the role of the National Alliance for Direct Support Professionals is exactly what we're doing today, is to offer, one of our roles is to offer information to this workforce that, and you've so eloquently stated, is a really kind of an alienated workforce, a low-paid workforce, a devalued workforce. So that said, without getting depressed and wanting to just go home and drink vodka all night, I don't want to do that, because I want to have a hopeful notion about what we can do. And I think that's how there's not many questions coming in from the audience, and that's fine. We'll do maybe one or two more questions and then we're going to wrap this up. But do you have, and with, again, you use the word, Amy, your ammunition, right? Data is ammunition that we can then take to those that make the policies, make the rules, and give us the bucks. Out of all this, what is your hope, each of you? Do you have, a hopeful, or I guess something to give us that is hopeful, that can change our system and our systemic issues? Do you have any hope and suggestions?
John, this is Amy. I'll go first on this one because it's so top of mind. And Robert's history, I think, really plays to it. I think we have to look at other female-dominated professions from our history, and three that are just glaring are teaching, nursing, and social work. All three poverty level wages at the very beginning. And so it gives me hope that if we can call this what it is and name it for the discriminatory aspects of the oppression of salaries and benefits, and follow the path that those other professions have done, which is something providers are going to have to agree to. But in this country, education, credential, or some kind of training that qualifies you and not somebody else is what's driven up wages in all of those professions. And so we can't really have it both ways. We can't and think that there's going to be hope that it will really change. we got to give something. And I think what we give is some required mandatory training and credentialing that is attached to significant wage increases. And so history really does give me the hope that we can make that happen if we quit running from required training and credentialing.
Thank you. Andrea, Robert?
And I would just add that, I get a lot of hope, primarily because I think that we're at a place where we have champions. You have a champion in the White House with President Biden. You have several champions in the Senate that has taken the initiative to introduce actual legislation, and there could be more, that will be introduced. You have champions in the House, and even naming the House Democratic Caucus's Aging and Families Task Force, where this issue has been brought to a very high level in which they're willing to champion. And so I think that leads us in a very good path, that not just this particular task force, but there's several committees that have jurisdiction over these issues. Education and labor comes to mind. In the Senate, you have Health Committee, who have all gotten on board, Senate Finance Committee members, to really say that they are willing to do something, and they have that ability to actually implement the change and to spearhead those initiatives. And without that, it's rarely successful. I mean, the challenge, I think, is that it currently may not be as much a bipartisan as it is a bicameral focus, but I think we're in a place where there are vehicles, like through the reconciliation process, to actually move these proposals so that they can be implemented. Mm-hmm. And without that, it would just be, a messaging bill. And we are in a place where at least we can go beyond that. Yeah. So I hope that'll be the case.
Yeah, it's I'm really glad we're ending, so to speak, on a question around hope and solutions, right? I had a colleague who used to say that criticism without solutions is just destruction. And so we really should be thinking about solutions and all of that. I would say from a policy perspective, the policy solution that I think gives me the most hope is a policy solution around a social insurance program in long-term care that would make LTSS more affordable to people who need it, and not require them to kind of spend on their income and assets in order to qualify for Medicaid or for other services, right? And they should be designed in such a way that they also improve jobs for frontline workers and supports for family and friends who are caregivers, so to speak. So, Washington State has a modest one, and I think hopefully it'll generate some attention at the federal level and also in other states. But to me, it seems that financing is so much at the center of these inequities and in long-term services and supports, that a social insurance program might go a long way to help that. The other pieces I would say is that I came out of the LGBT rights movement, and a big strategy in the 90s and in the 2000s was about the political aspects of coming out, and the argument being that the more that many of us came out in our families, in our jobs, and in our communities, often at great cost, that we would make it impossible for people to vote against it, and we would make people aware of the realities, right? And I feel that in many instances when journalists or people in government, et cetera, reach out to me or PHI with questions, when you hear the reasons why, it's because someone in their lives needs services and supports, and they've just realized how underfunded and dysfunctional that system is, right? And they want to change it. And so I'm hopeful, the metaphor doesn't work exactly, but I'm hopeful that all of us can come out in our lives about the realities of what it means to access services and supports, so that people in all the halls of power can really make a difference. I think the more that people realize the personal impact of this system, the more solutions that we're going to see. Yeah.
Well, we have come to the end of our time together, which has gone for me very quickly, too quickly. These things always go too quickly, in my opinion, because I think what you have given us, and you've given the people that have joined us today, and this is going to be archived, this information is critical for what we need to do to go forward in these hopeful measures that you just spoke of, each of you. And we're just very appreciative of you all and the work that you do to continue to bolster and fortify this alienated workforce. And I think we have a lot of work ahead of us. And I'm glad to be, and the NADSP is very glad to be working with organizations like all of yours to advance and make this a better world. Because our tagline has always been NADSP, making a world of difference in people's lives, and that's what it all comes down to. And hopefully, we're going to continue to do that with you all, and hopefully eradicate racism and do all those things that we've just talked about. So, Nicole, do you have anything else that we have to do technically before we sign off and say bye-bye?
Nope, I believe we're all set. Everyone should receive the survey, and on Monday, everybody will receive the recording.
Great. Our next installment of Black DSPs Matter Part 3 will be more on what we can do on kind of the micro level. As a direct support professional, as a direct care worker, what do we do when we face racism and the other things too? Because we're not going to avoid the sexist stuff that goes on and homophobic stuff that goes on and what have you. But obviously, our main focus is on the racial issues that happen in our society. And anyway, thank you all. We will see you down the road, and we hope to have a very good summer. Hopefully, a better summer than the summer last.
Thank you.
Thanks, John.
Thank you all.
Bye, everyone.
Thanks, everyone.
Thank you.
Bye-bye.